Good afternoon, good morning to everyone. I am Professor Sobha Sivaprasad from Moorfields Eye Hospital, London. Today, my topic will be on eyes on the future, transforming diabetic retinopathy screening globally through innovative technologies. So I'll try and cover 4 sections. The first one will be the importance of diabetic retinopathy screening. Section 2 is on diabetic retinopathy screening models. And then section 3 is key diabetic retinopathy screening programs and their impact, success stories, and challenges. And lastly, I will go through some emerging technologies that transform diabetic retinopathy screening for the future. So the first question we all would want to know is, why do we need to screen for diabetic retinopathy? So diabetic retinopathy is a asymptomatic condition. That is, the patients do not have any symptoms due to this in the beginning of development of the disease. And therefore, it is crucial that we identify those that are progressing to vision-threatening diabetic retinopathy. And that is why we need to screen these patients for retinopathy, because the patients will not be able to identify early retinopathy. By the time they identify retinopathy, it will be too late. They might have developed advanced stages of diabetic retinopathy. So I have a question for you. What region in the world has the highest increase in the rate of diabetes? Okay, so 8% got it right. It's China. So a lot of the attendees did mark South Asia, and it's sort of true because after China, it's India and Pakistan that are the most common countries with the increased prevalence of diabetes. So we spoke about diabetes just now. I now want to stress on diabetic retinopathy. So there are 103 million people living with diabetic retinopathy in the world today, and this is going to rise to 160 million in about 2 decades' time. So our next, why is diabetic retinopathy important? There are a few points I need to raise with you. First of all, diabetic retinopathy is the most common cause of visual impairment in working age group. So it is irreversible if it is discovered late, but it is preventable if identified early. And that is why diabetic retinopathy screening is very important. So you identify the disease and treat them early. You look at the global prevalence, 1 in 5 people with diabetes have diabetic retinopathy. 6% of people have vision-threatening diabetic retinopathy, and 4% have clinically significant macular edema. So the public health burden is extremely high. If you now look at an individual's quality of life as a result of any of the sight-threatening complications, they do not parallel the visual acuity. So people's quality of vision are often worse off than recorded visual acuity. And this will affect their work. They end up with disability during their working life. So we need to improve their awareness of this condition. Therefore, they look after themselves. So self-monitor, go to their hospital and get their diabetic retinopathy checked and treated if needed. Now, this is at personal level, but at global level, this is also a huge public health problem or a global health problem affecting several countries. And you can see the figure on the right on the economic burden. It runs in billions. So it is important that we all help reduce this social and economic burden of diabetic retinopathy. I have a next question for you. What is the most common sight-threatening complication of diabetic retinopathy? Is it macular edema, proliferative diabetic retinopathy, severe non-proliferative diabetic retinopathy, vitreous hemorrhage, or traction retinal detachment? Okay, 45% got it right. It's macular edema. So macular edema is now the most common of the sight-threatening complication. So I'll go through each step: who to screen, when to screen, and how to screen. So I have yet another question for you. Who should be screened regularly for diabetic retinopathy? Is it all people with type 2 diabetes from the point of diagnosis? Or is it people with type 2 diabetes age 40 years or older? Or all people with type 1 diabetes from diagnosis? Or only people with other diabetes complications? All people with type 2 diabetes from the point of diagnosis should be sent for screening program. So who to screen? Now you already know who to screen. If you go down to the screening schedule, for type 1 diabetes, you can start screening 5 years after diagnosis. But for type 2 diabetes, because of the late diagnosis of diabetes in most adults, they need to have their diabetic retinopathy screening at the time of diagnosis of diabetes. And diabetic retinopathy has several stages. So patients start with no diabetes changes in the retina, and then they go on to mild non-proliferative diabetic retinopathy, to moderate non-proliferative diabetic retinopathy, to severe non-proliferative diabetic retinopathy, and proliferative diabetic retinopathy. So they are marked in red, severe NPDR and proliferative diabetic retinopathy, because these are the sight-threatening complications that have to be screened and sent to hospital for treatment. The second aspect you see below is macular edema. So a patient can have no macular edema, or they can have non-central involving diabetic macular edema, or center involving diabetic macular edema. Again, it's the center involving diabetic macular edema that requires treatment. So we have various diabetic retinopathy classification system, and it started off with the ETDRS severity scale. So early treatment diabetic retinopathy severity scale. It was done as part of a clinical trial, and you can see how complicated that levels of severity is, from level 10 to level 81 to 85. And that was because at that time they saw so many features or lesions on the retina, but had to take them systematically to find out the lesions that caused the increasing severity. With time, we now use the International Clinical Diabetic Retinopathy Severity Level. The left-hand side, you can see no apparent retinopathy, mild, moderate, and severe NPDR or non-proliferative diabetic retinopathy to proliferative diabetic retinopathy. And way below, you can see no exudates and no apparent thickening within 1 disc diameter from fovea, or the presence of exudates in that area. So this is the most commonly done classification throughout the world. In the UK, for screening purposes, we use the National Screening Committee, or the NSCD screening. And you can see that the same grades are this time graded as R0, R1, R2, R3, and M0 and M1. These are done in this way so that if a grader identifies anybody from R2 or R3, they can be referred off. They are not vision, pre-proliferative diabetic retinopathy may not be vision threatening, but we do need an ophthalmologist to see that patient. And that is why R2 and R3 are referable retinopathy. And below you see M0 and M1, because M1 is the referable retinopathy. Now, we have diabetic retinopathy screening service in Wales, Scotland. Here, it's further broken down to make it easy for referral. So these are the types of classifications you use. If you choose one, you need to stick onto that so that people know exactly what you mean when you refer a case. Now, coming to various models of diabetic retinopathy screening, a patient can be screened anywhere, but there are 3 major types. They're the hospital-based screening models. These are very important in countries and areas where there are no systematic diabetic retinopathy screening services available. So These patients are mostly seen by a diabetologist, by his physician, by general practitioner, or in a polyclinic, or in even tertiary care. And it can be an ophthalmologist seeing the patient in secondary care. So these patients would then need to be screened there because they would not have had their diabetic retinopathy screening anywhere else. The most wanted or most robust way of screening is community-based screening model, so that all patients with diabetes have their diabetic retinopathy screening. But for this, you need investment, you need a systematic screening program, and these can be done either as a standalone system or at pharmacy, optical shops, or you can find your own area where this can be done in the rural area, especially when there are no ophthalmologist around, etc. And the newest model is tele-ophthalmology screening model. Now, this is where you have a combination of both community care as well as hospital-based. So patients get screened in the community, and then images are sent to a central area for grading. And this is usually placed in the hospital, or it can be placed in any area. And the images are graded there. Takes a few days for the patients to know about it. And then if there is referral, the letter will state that the patient has to be referred for an opinion or treatment. Now, that's been developed for over 20 years now. It's running really well in several regions around the world. But very recently, we have this artificial intelligence programs as well that can be integrated into the tele-ophthalmology screening models. And this will make grading much less time consuming. And I'll continue on that later. I also want to cover some guidelines for you. So you have the American Diabetes Association guidelines, you have the NHS UK guidelines, you have Australian guidelines, and you have AIOS and VRSI guidelines from India, and there are several other guidelines. Now, rather than going through all in detail, I think if you see a patient in a clinic and you have no cameras, no eye facility, the least you could do is to record their vision. If their vision is good, they can be advised to go to a diabetic retinopathy screening program to have their eyes examined for retinopathy. As I said earlier, good vision doesn't mean that they do not have diabetic retinopathy, so they still have to have their retinopathy screening done. If they have poor vision, 6/12 or worse, they should be referred on to an ophthalmologist because there may be several reasons why a patient has decreased vision. And it may be just refractive error or cataract. But of course, they need to rule out diabetic retinopathy screening as well. Now, there are instances when they do only screening without fundus photography, without vision testing. In that case, any patient with severe NPDR, diabetic macular edema, or proliferative diabetic retinopathy should be sent urgently to an ophthalmologist for monitoring and treatment. Now, our guidelines usually talk only about color photographs being taken to identify retinopathy, but with time now, we have also approached doing OCT in the screening programs so that you reduce the number of patients required in secondary care. Despite all the development we have with diabetic retinopathy screening, there are a significant number of challenges. I'll first go through the challenges that are seen more in low middle-income countries. And firstly, I explained already, there is lack of knowledge of diabetes-related complications in the eye. Secondly, there is lack of knowledge or awareness about the need for eye examination in people with diabetes because they wait for their vision to drop, which is too late. Next, there is a lack of knowledge about the availability of eye clinics near a person's living area. There's also cost and skill limitations in implementing retinal photography service. Of course, there's a global shortage of workforce, healthcare workforce for screening and treatment of diabetic retinopathy. We need the cost to set it up, so infrastructure and resource constraints are further problems. And of course, there is a lack of legislation and policy support. So if your government is supporting a diabetic screening program, it will be much easier to implement it than otherwise. And then financial sustainability. It is not enough if we just screen a patient at one visit. They need to be systematically screened regularly. And for that, you need financial sustainability. Now, if we try to sort all these problems out for both financial and workforce and absence of awareness of the disease, in upper, middle, and high income countries where some of these are not an issue, we still face problems. There are poor provider services. There is negative self-perception about a person's eye condition. There's a lack of communications between physician and patients. Then we ideally should be dilating the pupils to take clear photographs. And mydriasis is often, or dilatation of pupil, otherwise called mydriasis, is often a problem for patients, and therefore they do not turn up. There are also socioeconomic inequalities within middle and high income countries. And of course, there is always a reluctance to change behavior among all of us. One of the key challenges in diabetic retinopathy screening is many countries do have laws that do not permit optometrists to dilate their pupils without an ophthalmologist supervision. So in these countries, then clearly we cannot do diabetic retinopathy screening outside of an ophthalmology center where there's an ophthalmologist. And that's a huge barrier. With a solution has arisen now with the availability of non-mydriatic fundus cameras, because these cameras we can take images with these cameras without mydriasis. So it is non-invasive, patients find it more acceptable, it's portable, and it's ease of use, and it's cost effective. However, there are limitations. In low middle income countries, there are often a lot of patients with media opacities, and also we can't do this in eyes with small pupils. And of course, non-mydriatic fundus cameras can have a limited field of view as well. But if you imagine that you are in an area in the world where there are no diabetic retinopathy screening program, I would rather have a non-mydriatic fundus camera imaged on my eyes rather than nothing. So non-mydriatic fundus cameras are therefore hugely important to ensure global coverage of diabetic retinopathy screening. Now, I will go through some diabetic retinopathy screening programs and its impact, mention their successes as well as challenges within these programs. I'll first take UK National Program for Diabetic Retinopathy Screening. It's a country-wide population-based screening, a very successful program in many ways. And this was based on the St. Vincent's Declaration in 1989, where a declaration was made that a reduction in diabetes-related blindness should be reduced by at least 1/3 in Europe. Reduced by at least 1/3 in Europe. It's a huge undertaking, but UK has achieved it. You can see here the systematic diabetic retinopathy screening program started in 2003, whereby all patients diagnosed with diabetes should be sent to a standalone diabetic retinopathy screening program. Once that was implemented throughout England and Wales, you can see the population coverage increased over time. And at present, it has 81.5% coverage in 2020. And because of this, we found that we could urgently refer patients with vision-threatening diabetic retinopathy to a treatment center, and therefore diabetic retinopathy is now no longer the leading cause of blindness in the working age group in England and Wales. So you can see how dramatically about a 10-year investment in the national screening program led to a significant impact in terms of reducing the risk of blindness in these patients. In England, we do 2 field, 45-degree field of view, and we also use mydriasis for all our patients before we capture images. Images are then graded by trained technicians or optometrists and arbitrated by ophthalmologists. So it's a pretty well-established program at present. And there are, as you know, the number of people with diabetes are constantly increasing all over the world. These type of systematic diabetic retinopathy screening programs are difficult to sustain because the number of people with diabetes are increasing and they need annual screening done to them. So one way out to decrease the workload or decrease the burden of diabetic retinopathy screening is to extend the screening intervals in people with no diabetic retinopathy. And the second plan that has now been implemented is the use of optical coherence tomography, or OCT, within the second line digital surveillance clinic, so that only the screen positive center involving macular edema need to be referred into hospital. Despite all the plans we have and all the successes we have, we still have challenges. We do need to introduce automated analysis for grading, so that if we can say that an AI system is robust enough to differentiate a patient with no retinopathy versus presence of retinopathy, you already decrease the workload by approximately 70%. So it's very important that we try and implement automatic analysis for grading. Secondly, at present, we still use mydriasis for all our patients. And a better or more effective way out would be to use new camera technologies for screening. For example, staged mydriasis. That is, you try to take your image using new cameras or non-mydriatic cameras, and then use mydriasis only if the images are not gradable. So that's called staged mydriasis. And the field of view is approximately the same as that in standard cameras or desktop cameras. What we want to do is to have an ungradable image rate of less than 10%, and yet apply a very cost-effective service. I'll now cover Scottish National DR Screening Program. Here, of course, the country is much smaller. There are only about 200,000 patients with diabetes, but the coverage is extremely good. And what they do here is that they do staged mydriasis. And they also do only a single field, 45 degrees field of vision imaging. And they have incorporated OCT into their diabetic retinopathy screening program since about 3-4 years ago. So the advantage here is, of course, the workforce has decreased. You don't need to increase workforce as the number of people with diabetes increases, because you have automated grading for a considerable number of patients. The third is a study. This is a seed study from Singapore Epidemiology of Eye Disease Study. Here again, the images are captured at various sites. It can be polyclinics, hospitals, medical centers, optometrists, GPs, mobile clinics. And then these images are transmitted to the reading center, where graders grade these images. And then they are transmitted to the clinicians with the result. Now, with the integration of AI into this system, the results are usually transmitted within an hour to the clinicians and their patients. So clearly a remarkable improvement. Now, Los Angeles, of course, US is a high-income country, but there is difference in healthcare throughout US. So this is an example of a Los Angeles teleretinal DR screening program. And you can see that approximately 20,000 patients were graded, and they get about 11% of patients referred to ophthalmology. And the rest are so let me get that right. So 20,000 patients are screened, of which 20% have DR and another 10% have other conditions. So here they do 3 standard field protocols, and they dilate only if the image quality is not acceptable. So you can see now that there are various different ways of DR screening models. But end of the day, the aim of all these are to identify patients with vision-threatening diabetic retinopathy and maculopathy early so that they can be treated rather than wait for their visual acuity to drop. Here you can see the Los Angeles one. It needed a lot of work, but it did lead to a 89.2% reduction in waiting times. And what are the issues with that program? So implementation, of course, when you implement a DR screening program in any country, you'll be faced with several hurdles. One of being education and stakeholder support. So you need buy-in from the local health authority. Of course, you have to address skepticism. Why do we need this question? You need to increase access of care for these patients. And you also, if you're a general practitioner, you need to then collaborate with an eye care professional to send the patients off for treatment if they have referable retinopathy. So these are the barriers. There are also barriers in terms of decreasing workforce and implementation of telemedicine and the need for standardization. But the major impacts were the fact that we have an adjustment period, and it's also impacted by new EMR systems. So if your EMR, electronic medical record system, changes, we have a significant impact on the system, on the screening program as a whole. There may be concurrent changes in health policy. So today you may suddenly have a policy that come out stating that all DR patients need only be screened in a certain area or something like that. So that will derail whatever program you were trying to build. And for this particular study, they had only historical controls, so there were incomplete assessments of the treatment access as well. And this is a huge problem for any screening program, in that a screening program may work very efficiently in identifying patients with vision-threatening diabetic retinopathy. But there's a further step in that these patients then need to be informed, educated, and told to go to an ophthalmology center for treatment. And that communication often breaks down. And so patients do not turn up despite being identified as having vision-threatening diabetic retinopathy. So that's where there's a need for further assessment of these centers and linking up communications between them. Now coming to a low middle income country, this is Bangladesh. So here there's again no standardized DR screening program, but for the last 7 years, they have tried 2-stage DR screening in a few hospitals in Bangladesh, and you can see that they have used disc and macula focused mydriatic images. And the graders were primary optometrists, nurses, or paramedics, and of course they could refer to a retinal specialist if needed. So it is feasible in a low middle income country. So Smart India is one study that I led in India. So this is a multi-center cross-sectional screening study. So we had UKRI funded a large grant for us to establish DR screening program in India and assess their processes, estimate the prevalence, and come up with guidelines on how to run these services. So we involved 10 Indian districts and 1 union territory. We screened 42,000 patients, and we used a non-mydriatic camera. We took 1 disc and 1 macula-centered hemorrhage image, and we had a teleophthalmology program to 4 tertiary ophthalmology centers So you can see the results. 78% of patients had a gradable image. That's the very important point. And we went house to house surveying patients, mainly to prove that there is no primary eye care system in India. And therefore, could any form of community care for ophthalmology help identify diabetic retinopathy and any other retinal conditions? And you can see here approximately 3 million people aged 40 years or older had vision-threatening diabetic retinopathy and a higher prevalence in those with known diabetes. We found that of the 42,000 participants that we screened, 7,000 of them had already had diabetes, of which 4,350 had known diabetes, but the rest were undiagnosed. So a considerable number of patients don't even know that they have diabetes. Another part of that project, it's called the Ornate India project, and was the Nayanamurdam project that we started in India, in Kerala, in India. Now here, this is a particular example where the government was engaging. They wanted a diabetic retinopathy screening program embedded in their new electronic medical records that they had in their family healthcare centers. So you can see how a government buy-in helps us to very quickly establish a DR screening program within a primary care. So the government of Kerala already had an NCD registry, like many other states in India. It also had already 16 family health centers in Trivandrum district in Kerala. And of these, there were several staff in there that were trained to use the Remedio camera, which is a non-mydriatic camera. And this, a positive step here was the Remedio manufacturers themselves came in, worked with the government and trained the staff, and therefore were able to go through the feasibility quite well with them. So we enrolled 4,527 patients, and the images were transferred by PACS to the tertiary center, where they were retinal specialists, and they graded the images together with the graders that they developed. They were optometrists, and then positive patients, if they were positive or referral patients, they were then informed through the family health center that referred them, and then the patients were referred for treatment, either laser or anti-VEGF treatment. So this is called a complex intervention because you can see, despite government buy-in, there are several steps that we have to take to ensure that the pathway works. So what is the impact of doing such a exercise? So we realized that 1 in 3 people with diabetes in Trivandrum district had diabetic retinopathy, and 8% had to be referred for secondary or tertiary care. 38% were between the age group of 41 and 60 years, clearly stating the public health problem this condition has. And 99% of the patients were not aware of diabetic retinopathy and their consequences. All this costed only 400 Indian rupees for screening and treatment. So clearly, it's a very cost-effective way of identifying people at risk of blindness. At present, the impact is that the government found it cost-effective and have now implemented it throughout Kerala. So it's a huge impact, but everyone needs to initiate a feasibility exercise like what we did to ensure that it can then be implemented in a larger area, for example, a district, a region, etc. So these are the publications that you can read up about the complex interventions on the Kerala Nayanamurdam protocol. And the Kerala policy was that in addition to diabetic retinopathy screening, they also screened for all other end organ damage due to diabetes, like they had a foot examination, nephropathy check, cardiovascular check. And therefore, it became significantly valuable for patients to identify all complications of diabetes within primary care. And we have, of course, had two diabetic retinopathy screening guidelines in India as well as a result of all our efforts. Now, one big question we have is, as I mentioned in my first slide, people with diabetes are only increasing by the day. Whether we bring in workforce or whether we bring in AI, it is going to be a problem to screen these patients every year. So one way out is to identify the high-risk groups among people with diabetes to fast-track them for diabetic retinopathy screening and to control their risk factors so that they delay their development of diabetic retinopathy. Now, this is more a preventive approach. So instead of screening everyone at every visit, we do this prediction modeling and send patients for diabetic retinopathy screening in a triage. Everybody with type 2 diabetes needs screening, but because we don't have the workforce, is there any way of making it more cost efficient? So this predictive model will tell you which patients are very high risk of having vision-threatening diabetic retinopathy in the next 3 years, or even at present. And then that group then need to be referred off. The second groups, of course, will tell us what the risk is like and whether they could control their blood pressure, blood sugar, and cholesterol levels to decrease the rate of progression of diabetic retinopathy to vision-threatening diabetic retinopathy. So predictive modelings are really good and cost-effective. You have that for cardiovascular disease, you have that for nephropathy. So this is one such model that you could use for diabetic retinopathy. But I stress all people with diabetic retinopathy, with diabetes type 2 should be screened at diagnosis and regularly for after that. It's only the timing that will be reduced as a result of this predictive modeling. So the summary of key challenges in diabetic retinopathy screening program, of course, mydriasis, the challenges with policies that do not allow mydriasis, and most importantly is the quality of the images that are captured. Of course, you need cloud system if you need telemedicine, so that we do need internet system, and we need to try and do automated instant report and referral system so they can educate the patient while the patient is still with you. And then, of course, you need resources for image grading, training, and education. I'll now go on to the last point, and that is emerging technologies that can transform diabetic retinopathy screening. So artificial intelligence, as I mentioned earlier, can identify people with diabetic retinopathy, be it any grade. So if we have an AI, artificial intelligence tool that tells us this patient has no diabetic retinopathy very accurately, then that patient can stay in the screening program without a physician or a grader having to grade the images, because it's told you instantly that you have no DR. But if artificial intelligence identifies a patient with diabetic retinopathy, although there are many AI tools that do differentiate referable retinopathy from non-referable retinopathy, they can identify severe NPDR and PDR, it is still wise that we get those as accurate as possible, because all these patients need to be seen either for treatment or for prevention. So what's the benefit of AI? Of course, it's faster analysis compared to manual methods. It's scalable to larger populations and with higher accuracy in detecting early signs of diabetic retinopathy. However, AI is not without challenges either, because there is regulatory uncertainty, there are financial challenges, there is uneven financing and reimbursement schemes around the world, data privacy is an important issue, and of course, we don't like change. So doctors and patients may be resistant to this new technology. Some centers do not have the infrastructure to run a AI integrated screening program, or they may not have enough IT infrastructure. And of course, they may not have the adequate governance to run an AI integrated project. So there are significant challenges that one need to cross to integrate AI into DR screening programs. But that does not mean that it cannot be used. So this is one example that was done in Singapore. No, this is one that was done in Thailand. And you can see that in Thailand, they had a mydriasis and they had several cameras involved, and they integrated this into their electronic health record system, and they tested acceptability of patients and providers. This is a Scottish system where AI system is already integrated, and you can see how well you can see the accuracy of the screening programs, AI integrated screening program. This is the Thailand one where they used non-mydriatic cameras, as I explained earlier. Here, they came up with a few points that are really important for low middle income countries. That is, quality of images matter. You can apply or deploy a DeepMind learning system into a healthcare, but if the images are not good enough, we will end up with a lot of ungradable and inaccurate image grading. So this is what I already mentioned. When you implement, you need a streamlined referral system to an ophthalmology clinic. You do need an effective electronic record system. And of course, ungradable images and slow internet are significant barriers. And with time, if AIs are integrated into cameras, it will be a huge achievement because the patients can be given their results then and there. So this is the Ornate India, another part of the Ornate India project, where we looked at whether we could integrate deep learning grading system in non-mydriatic cameras. The one point I need to stress is the deep learning DR grading system was developed from images in another country taken on mydriatic pupils. Now, when you apply a deep learning DR grading system from a mydriatic retinal camera to a non-mydriatic community screening, we will face challenges because the AI system is not used to seeing poorer quality images or ungradable images as much as they would if they were using a standalone mydriatic camera. So Ornate India did a lot in India. It showed us that there is a way of integrating AI algorithm into a camera, and it's extremely accurate to identify referable DR from fundus image captured by minimally trained field workers in a home environment. So it can be done. There's a need for automation of referral DR systems so that it is much easier to implement this. DR models can learn to classify gradability of handheld two-field non-mydriatic retinal images. And for that, I would suggest that the deep learning model is built on the non-mydriatic cameras, on the images that was captured by the non-mydriatic camera. So Remedio has got one automated online DR artificial intelligence system in their smartphone fundus camera. The images are taken as macula and discentered. The AI algorithm is from Medio's Diabetic Retinopathy AI algorithm, which is offline. And this is integrated onto the smartphone fundus camera. So you take a fundus picture and almost click the button and you'll be told whether this patient has referable retinopathy or not. And this has been trialed in several countries. I can see in the right upper part of this, all over the world. And the reference standard is, of course, using certified graders and using the ICDR Diabetic Retinopathy screening program. One advantage of this camera is that they have got automated offline model to screen 3 disease areas, not only diabetic retinopathy, but also glaucoma and AMD. So you can imagine the impact this can do to people with the diabetes. It can soon spread to just ocular screening for anyone. This is yet another study that looked at a head-to-head comparison of 7 automated artificial intelligence diabetic retinopathy screening systems in the US, in Seattle and Atlanta. And this is very interesting. It clearly shows that the performance in Atlanta was better than that in Seattle. So one point that we need to know is why. And the reason is because the performance is as good as the quality of the images taken. This is why it's extremely important that the quality of retinal images are good, and then a rigorous AI is applied. So with this, I have some take-home messages. All persons with diabetes need to be aware of diabetic retinopathy. Patient education is key to success. All care providers should be aware of diabetic retinopathy and make sure that the patient is advised about screening for diabetic retinopathy. And all sight-threatening complications should be referred to a retina specialist for treatment. There are various screening models. I could go on for the rest of today. There are various types, but I think the forward-looking solution would be an AI integration into an existing non-mydriatic retinal camera as a first line for screening for diabetic retinopathy, as we really need a clear solution for insufficient workforce and increasing incidence of diabetes. Thank you very much. Do diabetic retinopathy severity levels relate to HbA1c? Yes, HbA1c is the strongest risk factor for diabetic retinopathy and its progression. Next question, is it possible to vision for a patient with diabetic retinopathy? Yes, if it is identified early. It depends on the stage of retinopathy. If it is severe, it is very unlikely for us to get on top of things. That is why early diagnosis is important. Do you know of any AI solutions in diabetic retinopathy? I just showed an example of Remedio camera having integrated AI. There are several AI systems. There was a slide where I compared several AI screening programs, and there are a lot around the world. What's the prognosis and possibility of VA improvement after management of DR complications? As I said earlier, it will improve if you identify the patients early and treat them early, but sometimes if it comes too late, it will be difficult to improve visual acuity, but we can mostly stabilize vision. Telemedicine versus AI in diabetic retinopathy. It's a complementary approach. So you can do telemedicine and get the graders, human graders to grade the images, or you can integrate AI into telemedicine and make sure that part of the system is being graded by AI. Shall a general ophthalmologist give anti-VEGF for a patient with clinically significant diabetic macular edema? As long as this ophthalmologist is trained how to manage, how to read OCTs, how to implement retreatment criteria, and how to add laser, how to switch patients, and how to stop treatment. So clearly there are a lot of things that general ophthalmologist should train to know about. Of course, if the general ophthalmologist can do the service, especially where there are no vitreoretinal surgeons around the world. Sorry for a patient who can't afford referral. That's correct, but there are government hospitals or there are hospitals where there are no charges where these patients can be referred to. There's always a need for quality assurance and clinical governance, which is clearly undertaken by the public health in England with the introduction of AI. Who will be responsible for QA, governance, the screening program, or the AI company? Now, this is a very difficult question. So we all know that is why this is being delayed in the UK, because it is not enough if a AI is of sufficient quality and is very accurate in identifying sight-threatening diabetic retinopathy. It's also the governance around it. As I spoke earlier, there's about data policy governance on that. So there are several steps to be taken, and that is what Public Health England is trying to do. How much is the cost of a smartphone attached tool? I wouldn't know. Please ask Remedio, which is one of the systems I know of that does it. Can optometrists advise for DR screening in India? Anybody can advise for DR screening. It's extremely important that all of us take that one point away today, that any of us can tell a person with diabetes, whether you're at home, in a restaurant, in a museum, or anywhere. If you're a diabetes, if a person tells you you are diabetic, I think it is our role to tell them that they need to have their eyes screened for diabetic retinopathy. That's the only way we can get coverage. How to do screening for peripheral ischemic retinopathy? Now, that is something we haven't started doing yet. It would take a significant amount of time, but if we can do screening according to the current classification, we will be, in effect, screening people with peripheral ischemic retinopathy. Do you think a screening program with AI should be a priority for lower income countries? It's easy for me to say yes, but as a question was raised earlier, we also need to ensure that the governance is correct, that the images go to the right person, you're grading the right patient's eye, reporting is correct, data integrity is maintained, data protection is ensured. So there are lots of other issues. But if there is nothing to offer, then yes, AI cameras will provide a good solution for areas where there are no ophthalmologists around to do the screening. So I'll give you an example. In the UK, you have a very good diabetic retinopathy screening program. And what we are trying to do is to see whether integrating AI will improve the efficiency of such a system. It is a different question if you're asking, can we use an AI integrated camera in a place where there are no ophthalmologists anywhere close by? There are people with diabetes with no primary care, and there is no advice given to these patients. Of course, then at least we should integrate AI into their cameras and get them identified early and treated early, sent somewhere for treatment. So you can understand it also depends on the scenario where the AI is being integrated. Do including OCT increase the DR screening efficiency? Yes, it does, definitely, because it reduces all the unnecessary referral for non-center involving diabetic retinopathy. It's always good to have a patient education when you are having screening to tell them that they have non-center macular edema and therefore they have to be reviewed for screening in about 4 months, but they don't need to go into an ophthalmologist to get their eyes treated. Can Remedio camera be installed in any camera? No, it has to be in their camera. Just for reference, I'm wondering how long is the wait for newly diagnosed diabetes patients to be screened in the UK? Well, they need to be seen and screened in 3 months, and most patients do have their screening done. It says as soon as possible, though. Doctors working in remote areas where OCT or V-scan not available, how can estimate the visual prognosis of cataract surgery in patients of suspected DR? Are you asking about cataract surgery in a patient with suspected DR where there is no OCT? Okay, you have to take the risk, do the cataract surgery, and then treat the patient for their diabetic retinopathy, because you can then see the fundus better. Kindly specify any possible training modules for using smartphone AI camera. I think you can contact Remedio and they may be able to advise you on that. AI with smartphone for screening, is it affordable in Africa? I'm sure it is affordable, and I mentioned all the governance issue around it, but yes, it is definitely affordable and available. What's the level of diabetes retinopathy in Pakistan? It's between 22% and 30%, almost everywhere. So, what's the average time it takes for a type 2 diabetes patient to develop DR if his diabetes is under control, less than 6 millimole for a period of 5 years? Very difficult to understand because despite diabetes being under control, because you develop diabetes, there will be microvascular changes in the retina, and therefore diabetic retinopathy can still develop. But it is the strongest risk factor, hyperglycemia. So thank you, everyone. I think we have answered all the questions.